EM board bombs.
And we're back. What's up?
Back.
EM board bombs.
The one and only.
The one and only, myself, Fat Hussein, joined by Dr. Blake Briggs.
Pleasure to be here.
I'm just eager to talk about the genesis of this episode.
Yes.
Which started with me sending you a text message. I'm just going to read this. Hey, we haven't done pneumocysticosis, right? How do you pronounce that, Briggs, by the way?
Pneumoconiosis.
Okay, I'm going to start that again.
You were just about 4 syllables off.
Pneumoconiosis. So I send you a message. I'm like, hey, Briggs, we haven't done pneumoconiosis, have we? All right. And then you basically respond by saying, that's boring. And then I'm like, yeah, but we need to cover some of these topics. And you're like, I'm just not excited about that. I'm just not excited about that.
It's been like 2 weeks in a row of no excitement.
Yeah, just no excitement. And then you're like, we just need to do something like sexy, a cool topic. We're like, all right, we'll do like MS. And then you're like, no.
That's not cool. No.
It's not cool at all. That's not cool at all.
That's the opposite.
And then finally, we're like, let's just do something off the wall, something we haven't done before. And then we've gotten a lot of requests for like oral boards or like oral board review. We're doing more like this like oral board type of presentation. So we figured, why not? Today's, maybe the perfect day for that, since we're not feeling the juice of like pneumoconiosis, MS, and all this other stuff, right?
You want to talk about coal miner's lung?
Coal miner, let's do it.
No, we're not.
So we're going to do oral boards type presentation.
Yeah,
bear with us while we do this. The first time we're doing something like this. Shout out to EM News, our only sponsor, emnews.com. You can go to their website. They have great articles. Briggs is a contributing member to that group. They are wonderful partners. And shout out to EM Rapid Bombs, which is, you can access it on emrapidbombs.supercast.com or go to emboardbombs.com and you can access the question bank right in there. We have more than 400 episodes there. It's an annual podcast. It's less than the subscription of Netflix. Netflix and all these other things are just like increasing their prices significantly.
Do you see what Prime Video did recently?
I know.
They do the ad thing before your video now. That was crazy. That was the last straw for me.
We just don't do it. We don't do that stuff.
We don't do that. No ads.
We don't do that stuff. No ads, nothing like that. It's like the price of like 2 coffees a month,
Correct.
So you can go and you can get multiple episodes delivered. You drop episodes throughout the week. We've got emails that go out that give you pearls 3 times a week, so you get this like high yield content delivered directly downloadable to your inbox and then to your brain. It's pretty awesome. Check it out, emrapidbombs.supercast.com, or just go to emboardbombs.com and click the question bank that we have.
You got it.
Hey, let's get into it. This is a new topic, a new thing we're doing.
I haven't seen this topic, by the way, listeners.
Yeah, Briggs has not seen this topic.
Flying blind.
It is flying blind. Oh,
okay. Maybe
we gave away. But okay, I'm not going to say anything. All right, let's do it. Okay. All right, so we'll start with the semi-oral boards type presentation here. It's going to be a little bit more difficult since we're doing this in podcast form.
But try to remember how to take oral boards. I haven't done it in a while.
Let's do it. I know it's been many a year for you with your gray hairs. Yeah.
Yeah. Don't make fun of me. It actually has been a few years.
And we present the patient. So you've got a patient who comes in, chief complaint, came in via EMS, chief complaint of a 68-year-old male with headache associated with nausea, vomiting. Vital signs are heart rate 109, blood pressure 170/94, respiratory rates 18, O2 sats 100% on room air, temp is 36.5 degrees Celsius, patient's weight is 70 kg.
Great. So what do I see, hear, or smell, as people have said? Sometimes taste when I walk in the room.
Oh, yeah, those all together. So the patient's appearance is he overall just doesn't look comfortable at all. He's got his head in his hands, his eyes are closed, but he's speaking to you in full sentences, appears to know what's going on.
Can I get the patient on the monitor, and can I also have large bore IV access?
Sure.
As they always say to do on the boards.
IVs in. Yeah, exactly. Yeah. You got it.
And the nurse is looking at you like, what?
You got 2 18s going, baby.
That's great. I prefer 16, but it's okay. And let me talk to the patient. Is he able to talk? Can I assess his ABCs?
He's gonna talk. Yeah, full sentence. Yeah, ABCs. So he's speaking in full sentences,
Right.
breathing. He's in no respiratory distress.
Awesome.
He's got good distal pulse. The skin's nice, warm. Yeah.
Great.
He's ready to talk.
He's ready to talk. He's ready to tell you.
He's ready
What's
to
going on with him? What brings you in today, sir?
Yeah, so I've been having this headache, and I also had some vomiting with it. I was over at my friend's house, and all of a sudden, I was feeling fine before, but then all of a sudden, just got this headache right kind of in the front of my head, right behind my eyes. Again, I just haven't had it like this before.
Have you had any vision loss, vision changes?
Yeah, I mean, it's light sensitivity. For me, is how I describe it. Maybe some vision issues as well with this, but honestly, it just makes it easier for me to just close my eyes.
Okay. Is it both eyes or one eye?
I think maybe more one eye.
Which eye?
So my right eye is hurting a little bit more than my left.
Okay. Got it. Any fever?
No, I haven't felt any fevers. Again, this all happened pretty quickly. I was feeling fine before. I was just hanging out and just like watching a movie with a friend.
Okay.
This happened.
Got it. Okay. Has this ever happened before?
Never.
Okay. You take any meds for anything?
Yeah, I take some blood pressure stuff. It ends in a Pril, and then take aspirin, and I've got like a cholesterol medicine I take.
Got it. You smoke?
No, doc, I don't smoke. I quit smoking like 30 years ago.
Any alcohol use?
Sometimes, occasionally, not today.
Any drug use?
No drug use.
Okay. Any trauma to your head, face, anything like that?
No, nothing like that. I was just sitting watching a movie.
Okay. Got it. Did the light bother it?
Yeah.
Okay.
I don't want to look at you. Sorry, my eyes are closed, and I don't want to look at you right now.
Oh, that's okay. Any prior surgeries?
Yeah, I had my gallbladder out. I've had my appendix out too. I've had some cataract surgery.
Okay. All right, let me do my physical exam. Give me a general appearance.
Again, awake and alert, just in some distress.
Okay. Let's do an HENT exam.
So head exam is normally traumatic. Eyes, complains of seeing halos around objects. Extraocular movements intact, no periorbital edema, right conjunctival injection.
Okay.
And neck is normal, heart normal, lungs normal. I know I'm just getting through this, but lungs normal, abdomen normal, neuro exam, again normal, other than some of the vision.
Yeah. You were a very
patient
gracious
describes.
board moderator, because normally they wouldn't just give all that out. So thank you.
You're welcome.
Let me ask some specific details here, because I feel like you're leaving stuff out intentionally to make me fail the old boards. Thank you, though.
You're welcome. You need to ask.
I'm sure you work at a university, like most board examiners. So I'm going to flunk this doc. So, hey, give me the visual acuity, please, for the patient.
Oh, okay. So you're asking more questions here.
I need
So,
specifics. Yeah.
visual acuity. So left visual acuity is 20/30. Right is 20/200.
Okay.
And remember, when you're, just to let testers know, when you're on oral boards, you can ask for anything you want
You
in
just
terms
gotta
of
ask.
the exam, right?
Yeah.
So you can ask
Can I get a
for
coffee,
all-
please? Coffee?
Do that too. All right. So you got
It's
visual
virtual
acuity,
now. You
so-
can't get that.
I know, right? Left eye visual acuity 20/30. Right eye 20/200.
Ooh, gosh. Let's do a slit lamp.
Sure.
Yes, you can do this, listeners. You can ask for a
Exactly.
slit lamp.
But you have to ask. They're not going to
Yeah.
just give you the slit lamp exam,
No.
right? They'll give you
This
a
is
little
easier than doing a slit
abnormality.
lamp.
Yeah. They'll give you a little abnormality on physical
Yeah.
exam, and then you can dig into that some more.
Got it.
So slit lamp exam, I can give it to you since you asked. Right cornea is cloudy, hazy. Right anterior chamber appears narrow. No cell or flare.
I feel like I have to keep asking for things. I need the intraocular pressure as well.
Yes, and since you asked, I can tell you by the intraocular pressure. So right eye intraocular pressure is 66. Left eye is 14. I would not have told you that if you did not ask.
All right, so I'm ready to discuss treatment plan for this patient and some blood workup, all that.
Wait up. Let me just interrupt you real quick.
Okay.
Let's talk about the differential. So as we know, it's important to give a competent differential.
Yes. Yes, so differential would include glaucoma.
Sure. Yeah.
Think through this.
You want to be a little more specific about that glaucoma?
acute glaucoma.
Yes. Acute angle. Yes. What we need
Oh,
to know.
yes. Yes, thank you. You're not supposed to agree with me, but okay. We'll say migraine headache.
Okay.
We'll say retinal detachment.
Okay.
We'll say vitreous hemorrhage.
Sure.
That's pretty good. And lupus. I added that for all mine when I was
You
taking
use
oral boards.
lupus for everything. Yeah.
Yeah,
I know.
lupus for everything.
Or like MS for everything.
Chronic
All
Lyme, MS.
There you go. There you go.
Ehlers-Danlos, its activation.
Oh, God. Go to your actions now.
Yeah. So patients on the monitor now. We got IV access. We'll send off some
Yep.
laboratory studies just in case, even though they have nothing to do with today's workup.
Yeah, well, lab studies.
Yeah, we'll do some just CBC, BMP. Sure.
Sure. Reasonable.
Yeah, great. Okay, let's do a treatment action plan here since he has elevated IOP. I would like to start with timolol, please.
Oh, wow. Okay. We're going right to it.
Going right to it.
Sounds good.
Going right to
All
it. And I need to place a consult for ophthalmology, please.
Okay.
Yeah.
So ophthalmology gives you a call back. Hey, doc, what do you need? It's,
Hey, golf. I'm
opto
golfing.
doctor.
Sorry if you hear drinks clinking in the background.
Yeah. I'm golfing on my boat right now. I've got my tee all set up, and we're going boat to boat and golfing.
Yes.
So stop
In the
bothering
Bahamas.
me.
Day flight.
Yeah. Yeah. I can have my jet on standby. I
Sir,
gotta
I
take my
need you-
helicopter to it, though.
Sir, I would like you to come evaluate this patient. I have an acute angle closure. Welcome.
Wait, why do you think that?
Based on the intraocular pressure measurement as well as my slit lamp examination.
You did a slit lamp?
I know, it's weird, isn't it?
Do you have those things in the ER?
We do. We recently purchased one in our budget. Actually, you advised us to get one, and we agreed.
Well, that's fantastic. Oh, what have you given the patient so far?
Timolol so far.
Great. Anything else?
I'm about to give them something for pain.
Okay.
And some other
that
meds.
sounds good. Why don't you just keep giving them the Timolol? I'm a bit busy right now. I'll see him tomorrow.
I need you to
clinic.
come now, sir. I need you to fly your helicopter back to town.
Well, I'm not going to be operating on this patient, Dr. Briggs. Just keep up the Timolol, and I'll see them. What's the issue here?
All right. I'm going to call back in a few minutes, and love you to come back.
Okay.
Get back to the EA.
Okay, fine. If you're really being that insistent, so this is important because oral boards, they will try to basically see if you'll delay having the consultant come in. But
Gotta be a patient
as
advocate.
we know, yeah, you got to be the patient advocate,
Yes.
and this is one of those situations that opto requires emergency consultation, not
Yes.
on just the phone, but they need to come in here.
Yes, exactly.
Great. Okay.
Great, awesome.
So, all right, Dr.
Thank you.
Briggs, I'm going to come in. Let me get in my helicopter, and it's going to take me to my plane, and then my plane will take me into the hospital.
Sounds good.
Thank you.
All right, safe travels.
Thank you.
All right, so I'm off the phone. I'll give the patient some IV morphine for pain control.
Great.
We will also give the patient anti-nausea medications. We'll do some ondansetron. And then we'll also do acetazolamide IV as well for treatment of his glaucoma. He's got those two agents going.
Great.
And that's really it for now. How's the patient's IOP when I recheck it?
So, thanks for rechecking it, by the way. Patient's repeat IOP is now in the 40s. It has improved.
Okay. We'll keep giving those treatments as scheduled.
Okay.
Consult pharmacy for dosing. And
Great.
that's it. Let's wrap it up. Admit the patient. Done.
Done. All right. And ophthalmologist comes walking right through very
Yeah,
quickly.
that's a fast plane. He was on a
Fast plan.
he's on a
There you
Blackbird.
go.
All right,
There
what are
you
the
go.
critical actions?
Yeah, so let's
This is
get into-
important. This is important, by the way. Then we'll wrap
Yeah.
this thing up.
So there are different ways that you can approach things and different steps sometimes you can take, but there are critical actions that you are going to get graded on, and if you don't hit those critical actions, that's how you can potentially not pass
Yes.
or do well on an oral board. So let's get into those. You need to do a good eye exam. You got the inkling when we told you that we mentioned that there was right conjunctival injection, right? And that should have been your first kind of clue into, okay, I need to dig here, or the concerns of like blurry vision and eye pain. So thorough eye exam was critical here to ask.
Yes.
We talked about visual acuity. We talked about intraocular pressure. Remember, on oral boards, you can ask for a slit lamp exam all day, every day.
Yes.
That slit lamp is always going to work, and it's going to tell you what you need to know. And they're not going to be like, what exactly are you looking for in the slit lamp? They'll tell you what the slit lamp examination is. The other one was administration of glaucoma medications. Obviously, you're dealing with acute angle here. So the timolol was critical to know. You need to know that as a treatment therapy. You don't necessarily need to know like how often and then keep rechecking eye pressures every few minutes. That's okay. You need to know that that's something you need to give the patient. The timolol or any other kind of beta blocker drop. And then frequent administration is important also. Again, you don't have to give exact timing, but just understanding, hey, let's keep giving the drops, or you can consult pharmacy to get recommendations on how frequently to give the drops, and rechecking. So that is critical. Rechecking the intraocular pressure, as you did, Dr. Briggs, would be really important. And the last critical action item here was emergency ophthalmology consultation. So that's not a phone consultation where you just get recommendations over the phone. And they will do that a lot, is they'll say, okay, well, we have recommendations. This is what to do, and follow up in clinic. No, this is emergency consultation. And they'll try to have the consultant basically say, do I really need to come in right now? And you need to be that patient advocate. So those were the critical action items. And then we can get into some of the other things too.
And we know in real life that the vast majority of consults can be over the phone, in the community practice especially. To residents, you might be used to calling a consult and you expect either a resident or APP to come downstairs from the hospital because you probably work at a major center. But in the community, we all know that the majority of your consultants are at home and they're not going to come in, actually. So I understand that can be maybe a tough pill to swallow on these boards, that you may accept the answer of, okay, they'll see him in the morning, that's great. But on the boards, they expect you, essentially, this is like a testable item. They want you to basically push the consultant to come to the ED sooner, even in cases where in real life that's not really necessary. So just remember that. That may be something that may be against your practice style if you work in the community, but don't worry, you're supposed to do that.
Yep, exactly. So
cool. And that's it, really.
Yeah, that's really it. Again, you're dealing with acute narrow angle glaucoma, and
pretty straightforward.
It really is. I think recognition is the key. I think the areas where you're going to be tripped up is that patient who comes in and everyone thinks they just need a migraine headache. Or you're getting like CT head imaging on this patient, or you're anchoring and thinking about subarachnoid and all this other stuff. Because you'll have those patients inevitably. That's why getting a good eye exam in on every headache patient is absolutely critical. And we kind of gave this away with the whole like watching a movie classic board question, right? Is they were, a patient with like a history of hypertension is in a movie theater and they're watching a movie. Exactly. They're watching a screen, and then it all happens then, because that precipitates the whole narrow angle, acute narrow angle. But again, we gave you some of those breadcrumbs, but it is critical on every headache patient you have to do an eye exam. And then immediately on eye exam, that was kind of the tipping factor to get an even more detailed ocular exam to be done. Those are really the main areas where you could potentially trip up. Okay, Dr. Briggs, let's get a quick summary in. This is like for our short, right? Short video here for our YouTube shorts. What's a good summary of acute angle? And now take me into presentation, kind of that recognition part, what you would do, and then treatment.
Sure. So angle closure glaucoma is going to be a presentation of headache, painful vision loss. And that's the key here. Sometimes the eye appears red, halos around objects, nausea, vomiting, photophobia. It seems like a migraine, except it's sometimes unilateral, usually frontal, usually retroorbital to some degree. And it's going to be that classic, as Iltifat said, bright light to darkness transition, classically walking movie theater or dark to light room, whatever. And it causes the pupil to dilate, and that pushes the iris against essentially the part of the eye, getting the details, but part of the eye that's going to close off that area, and then they're going to build up pressure, boom, done. So what you're going to have on the exam, I love this quote here. It says, a steamy cornea. It's steamy looking.
Steamy, I know.
It's cloudy and hazy due to swelling. And the slit lamp, hey, let's say you're listening to this and you're like, whoa, I haven't done a slit lamp in forever or ever in my career. That's fine. Just do intraocular pressure measurement, and that's going to be the diagnosis. And it's going to be high, like 40 to 70 high. Normal range is 10 to 21. So anything less than 20 is considered a normal IOP.
Right.
Ophthalmologist is going to have to come in to do some laser stuff. It's going to be great, going to be complex. That's why they get paid a lot. And they may do that in the morning, but your job in the evening is to watch that patient. So this is a patient that should not go home. This patient's being admitted to the hospital or they go to surgery. And so what you're going to do in the meantime is give a bunch of meds. One, treat their pain and nausea. The more pain and nausea they have, the higher the pressure in that eye. So lower that with pain and nausea meds. The second is going to be, of course, your anti-glaucoma agent. So timolol is the cornerstone here. It's intraocular. It has to be frequent dosing. It is the cornerstone therapy. If that's the only med you give, that is the best med to give. Other meds would be acetazolamide, which is IV. That's some sideline meds you can give. And then bromotidine, aproclonidine, whatever. Those things are kind of down the line. But the best one is going to be timolol, acetazolamide. Those two are the best. There could be other meds you consider that ophthalmology may want, like steroids, pilocarpine, whatever. Those, and mannitol even. Those are down the line. Again, that's after you call ophthalmology and get some feedback from them. Of course, if you're in the community and you don't have an ophthalmologist, of course they're being transferred to a center with ophthalmology. If you're at a center with ophthalmology, you're talking to them and they say, hey, I'll get to it in the morning, you're probably going to have to admit that patient because they're just not going to be able to go home with these meds and lower they're not going to be able to measure the pressure themselves. So they're staying in the hospital. And that's it. Done.
Nice
I
little
passed my
summary
boards.
there.
Can I still practice?
You did. You can practice.
It's under consideration. The board has to meet.
The board has to meet. Yeah, they'll figure it out. I think they'll make an exception for you there, Dr. Briggs.
Thank you very
They'll
much.
just listen to this podcast and they'll say, this guy. We need
know
this
him.
guy practicing.
We know him. Yeah.
Hey, shout out to Foundations of EM.
Yes.
We
appreciate their
we're able to-
information on this.
Exactly. We use
Good
a lot of their
resources.
cases to teach. Yeah, great resources to teach residents.
Yeah.
Pretty awesome.
Cool. That's
All right,
it.
Briggs. That's pretty much it. We're not going to do our Reddit corner for this one.
No.
We're going to be back to our regular scheduled programming with Reddit corner and other things when we find a topic that...
When we
that's
cover
gonna actually
pneumoconioses.
get-
Yeah.
Pneumoconioses, there you go. Okay.
Yeah, take a break from that week. All right. We'll catch you next time.
Stop it. See ya. Bye.
See ya.